Our webinar today is entitled Supporting Parents Through Pregnancy After Loss. I would like to review some information before we get started. The planners and speakers do not have any financial disclosures to make. Immediately after the webinar ends, as well as in an email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. To receive a certificate of completion, including 1 nursing contact hour, you must log in, listen to the entire webinar, and complete the evaluation survey. Certificates of completion will be sent via email within 1 week of the webinar broadcast. The program is being recorded and will be available on the partnership website and YouTube channel until October 20th, 2023. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write questions in the question box, and the speaker will respond to as many as possible at the conclusion of the presentation. I will now be turning our presentation over to the Program Manager of the Perinatal Mood Disorder Initiative at the Partnership, Evelise Gonzalez.
Thank you, Andrea. Good afternoon, everyone. So I am, like Andrea had mentioned, the manager for the Perinatal Mood Disorders Initiative at the Partnership for Maternal and Child Health of Northern New Jersey. For those of you who are unaware of our organization, we are a nonprofit committed to improving the health of women, children, and families. I encourage you to visit our website at www.pmch.org to learn more about the different programs that the partnership provides and to see which ones are available in the areas that you work and live in. At the end, I will talk about our postpartum depression's emotional health phone support program, as well as our free perinatal loss support group that is through our FEMUR program. Both programs are funded by the New Jersey Department of Health. Today's presentation will be done by Lindsay Henke, clinical social worker and maternal mental health therapist. Lindsay is a psychotherapist specializing in perinatal mental health based out of Minnesota. She provides psychotherapy in a private practice setting, specializing in reproductive trauma, infertility, perinatal and infant loss, and the pregnancy that follows along with postpartum anxiety and depression and mental health treatment. She is also the founder and executive director of PregnancyAfterLossSupport.com. Lindsay, I want to thank you so much for taking time out of your busy schedule to be here with us today. For those of you who are watching, please feel free to utilize the chat box to ask questions. We have a lot of ground to cover, but we will try and leave some time at the end to get to your questions. So let's go ahead and get started. Take it away, Lindsay.
Hi, everyone. It's nice to be here. Thank you for having me, and I'm excited to talk to you about supporting parents through pregnancy after loss. That is my professional bio. Also, the reason I came to this work, like many others in the field, is because I also experienced my own full-term stillbirth and then 2 subsequent pregnancies afterwards in my personal life. So I will use examples of myself and of my clients and from research as we go through this presentation. I wish I could see all your faces. It feels more interactive, but we do what we can with what's going on right now, right? Okay, so I wanted to first, I'm here today to talk about supporting parents through pregnancy after loss, but we're going to go through the whole kind of psychology behind how we get to that point, because it doesn't start with the pregnancy after loss. But first, here's a picture of me in case you can't see me. I don't know if you can or not. So I'm a licensed clinical social worker. I also specialize in maternal mental health, and I'm the founder of PregnancyAfterLossSupport.org. .com will get you there too. But it is a national nonprofit to support those who are subsequently pregnant after loss through peer-based services, an app, and an online magazine and support groups, which of course came out of my own experience of seeing a need for something when I was subsequently pregnant. So I have to make a disclosure that the planners and speakers, me, have no financial disclosures to make. And I think I don't have to read the rest of it, but it is in here. So there you are. So the objectives today are to identify the emotional complexity of the pregnancy that follows a perinatal loss, including the processing of grief, anxiety, attachment bond, and coping during the subsequent pregnancy. We also want to identify and implement interventions and resources for you guys to help support your clients or patients that are pregnant again after a loss. And then we also want to discuss why implementation of special considerations in and among healthcare providers and support workers can or could reduce anxiety, depression, postpartum or post-traumatic stress symptoms in parents during the subsequent pregnancy and into the postpartum period, with also the hope of increasing a successful attachment with baby, and doing so specifically in BIPOC communities. So like I was saying in the beginning, I was just jumping right into my presentation. So if you're trying to talk about pregnancy after loss, you can't really talk about it from just that point. You have to go back to the unique grief of perinatal loss, so when the loss occurred. So perinatal loss, some background here, how common is it? As a lot of you probably know since you're in this training, 1 out of 4 pregnancies ends in miscarriage, 1 out of 160 pregnancies end in stillbirth, and this isn't even taken into consideration other causes of infant death or neonatal loss, including SIDS or preterm birth or preterm labor, which I've heard different statistics being thrown around by the March of Dimes, which can be either 1 in 9 or 1 in 10 babies are born premature. And not all prematurity leads to death, right? But these are other reasons that cause the loss of a child during pregnancy or soon after. So it's really common. I mean, I've heard another statistic that we used. So I've heard another statistic that like 1 million women or birthing persons experiencing a loss, some kind of pregnancy loss in the United States a year. So it's a lot of people. So more statistics though, if we break it down even further, as we've become, in the last couple of years, I feel like we've become more aware of just as a public, just how much BIPOC communities are affected by maternal mortality and infant mortality. And that includes pregnancy loss and stillbirth. So Black women are more than twice as likely to experience stillbirth compared to Hispanic and white mothers. Black women have a higher risk of pregnancy loss compared to white women, with an increase of 43%. Black women have higher rates of infant mortality than white women. And the underlying cause that make Black women more susceptible to pregnancy loss are various issues of racism and systematic inequality and implicit biases in the healthcare setting. And this is all according to the most recent research by the CDC. So we'll talk more about different specific populations as we go through this, but I will have to say that I've been giving presentations since 2014 on pregnancy after loss, or maybe 2015, and the research has changed over time. I've been able to find more research, sorry, I'll go back here, about different BIPOC communities in the field to look at to see what is being looked at for support or lack of support, or how their experiences are with grief and pregnancy after loss and postpartum. But it's just starting to emerge, these research studies that I've been finding. They weren't there in 2015, 2016, 2017. A lot of the ones that I've been actually referring to for this presentation as well, they didn't come out until 2018, 2019, 2020. So I feel like there's an emergence of more awareness of how pressing the concerns about Black, specifically maternal mortality and infant mortality is, and especially in the loss community, it is, these are the families that are losing more babies. So we want to be very considerate of how the experience of grief and pregnancy loss affects them. And there are some differences in the research. So if we start with grief, if you're working with clients, as you probably already know, you really want to, who experience a pregnancy loss of any gestation. So when we talk about pregnancy loss, we're also talking about miscarriage, stillbirth, infant death, which we covered. All these losses result in grief. And we want to normalize that grief is just a symptom of love. It's a healthy reaction to a pregnancy loss, and grief is often defined as emotional reaction to loss shown as shock, numbness, anger, guilt, sadness, and anxiety. And this is just part of the normal and natural innate healing process we go to. Grief isn't pathological. And sorry, there's thunderstorms here, so I hope this works out okay. But we really want to normalize that. Like, yes, of course, you would experience grief because you lost your baby. I know this seems silly that you would think otherwise, but since you've probably worked with this community, a lot of people in the community experience disenfranchised grief or ambiguous loss, where their family and friends don't really acknowledge how big of a deal the loss of this child has impacted them, and so how that affects their psychological state. So the grief, and I'm kind of getting into that already, this slide bleeds into this one, the unique grief of perinatal loss is even more defined. So grief associated with pregnancy loss differs in ways from other forms of grieving, others we've lost. So for example, one reason friends and families might not really validate this grief is because there's no shared history, there's limited memories to reflect on, and it's more of an attachment for some, viewed by others of the family. It's not just an attachment to the baby that is at the time, but it's also attachment to an anticipated future with the unborn child that is no more. And so others outside of the family system aren't able to actually engage with this expected baby as much. So when the baby dies, it's more of an isolating experience for the couple that has lost the baby. So women who experience perinatal grief also report feelings of guilt and shame. So that's the idea that I'm sure you've heard some of your patients or clients talk about, that there's this failed maternal body. That's what the theory is called now. We can talk about change in language, which is also needed in this area as it comes to being more gender neutral, and talking about birthing persons, which, as I bring to light, a lot of these studies right now are done on women identifying people, and there isn't a lot of research out in the field yet about differing gender identification and birthing persons. So that's another area where research in this area needs to go a little bit farther to explore unique experiences that way. But during the presentation, I will go back and forth between women, birthing person, just to let you know. But so women who, according to the study where this research is pulled, women who experience perinatal grief also report feelings of guilt and shame. That's that theme of my body failed me, that we refer to that as the failed maternal body. There's an emptiness, a sadness, an anxiety, an emotional detachment from themselves or others. And there's also those somatic symptoms. So like those body symptoms, like there's a stomachache or headache, or, you know, like your body responds to stress in different ways. So one thing to note when you're thinking about perinatal loss and grief is that the intensity of the grief is not determined by the length of the pregnancy. Different research studies show. And this is a really validating statement I use with a lot of my clients, because those who have, there's this thing called comparative grief in the loss community. So it's this, there are the grief Olympics, like, is my grief worse than yours? And there's been a lot of talk about that just in the grief community in general, as grief has become more mainstream on social media. But what researchers say about perinatal loss specifically is that it is thought that more the mother has experienced a comprehensive reality of the baby, the higher the level of the grief. There is some research that finds that, but contrary to these findings, however, are a number of studies that basically say that there is an association between length of gestation and level of distress after loss. They could not find an increase in psychological distress with gestational age of the loss. So it's a really validating statement for a lot of my clients that if I have a miscarriage, my grief is real and intense. My experience might not be the same as someone who has stillbirth, and I still lost a baby, and my grief is valid. So really we want to validate the grieving person's experience, right? Because common themes in perinatal loss that come up for our clients and patients that eventually become pregnant after a loss are these feelings of isolation and loneliness due to stigma and silence about pregnancy loss. This month, October, is Pregnancy and Infant Loss Awareness Month. I feel like we're becoming better, even in the, I think it'll be 9 years in December since I've been in the community, the loss community. I feel like we're getting way better in the last 9 to 10 years for how we talk about perinatal loss. But I also, when you're going through it, even for my clients now that are going through it, and especially during the pandemic, it's actually been, I feel like we've taken a couple steps backwards with that feeling of isolation and loneliness. There's the invalidation, like I talked about, the diminishing of loss by friends and family, lack of support from significant people in their lives because they don't see it as a loss because the loss happened to the couple. The person who experienced the loss and the parents view the loss as a major life event, and it's often viewed as a traumatic event for them, which I think is becoming more and more understood in research. And of course, by the people who go through it, well, I'll get to that in a second, they would say, well, of course, a pregnancy loss and ectopic pregnancy is a traumatic event. I remember it that way. But now there's actually been recent studies that have, like, and people are like, why did I need a study to validate what I already know about myself? But there's also been large cohort studies showing that pregnancy loss is a traumatic event for a lot of people who go through it because it is often sudden. There is no like warning or lead up to it, and it's happening to the person's body and to someone they love. So it's often, it meets criteria for a traumatic event. And it's also, perinatal loss is the combination of what I like to say, grief and trauma. And one of the things that we hear a lot from our clients and in the research is that we lack cultural scripts to help bridge the gap between the parents, the bereaved parents or the parents that experience the loss, to the greater society. But I think we're getting better at that. And when you're going through it, it still feels isolating and lonely. So one thing that can happen is that grief can become complicated. So let's remember that grief is a natural and non-pathological response to pregnancy loss. But complicated grief is when the symptoms are more disruptive, pervasive, or long-lasting than the normal grief response. Knowing that a client's not going to be over their grief within a year from their pregnancy loss. So we have to be careful as to what we define as the length of grieving process. Complicated grief is more likely to happen when the grief has, or the loss has been sudden, violent, and traumatic. And a lot of my clients and patients that I've worked with do, and you've probably seen this as well, view their early pregnancy losses as kind of a violent occurrence. Like, violence wasn't done to their body, but there, I'm gonna get kind of graphic, there is a lot of, for them, like blood and the lack of control. And to them, it can, I've had clients refer to it as, it almost seems violent, but definitely seems traumatic, right? So it's important to know that grief usually peaks, natural grief usually peaks within approximately 6 months of a loss. And this is, they did this study in 2012 and 1996, and they're finding that grief from losing like a partner or, you know, a parent usually peaks approximately within 6 months of the loss. And the same can be found true for perinatal grief. And I often see that my clients start to hit a different wave or period in their grief around that 6 month period. So complicated grief and perinatal loss, we've kind of gone over this, but common themes reported feeling in both would be sudden and unexpected, no time to prepare, early losses, there's no funeral or ritual to help with that jump-starting that natural grief process, there's no baby to hold, which in stillbirth often jump-starts that natural grief process, is what research shows. Sorry, my nose is a little runny. So there's also often a feeling of guilt and self-blame, that failed maternal body, and then that their bodies have failed them. Risk factors for complicated grief include a history of previous pregnancy losses, previous mental health diagnosis, lack of support from friends and family, poor marital relations or support from partner, lack of living children. So if this is their first experience of loss, there seems to be more compounding complicated grief factors, which the research and literature shows, and then terminating for medical reasons. Having to make choices about your baby's health and future can also compound and complicate the natural grieving process. But I think it's this new study that came out in, so it came out during the pandemic, which feels like the last, whatever, 20 months has been 2 years and 1 year all in the same. So I think this study, yeah, it came out in 2020. I think it was January of 2020, but it was done in 2019. And it's basically this idea that perineal loss as an experience is an experience of trauma, like I said. But this study, post-traumatic stress, anxiety, and depression following miscarriage and ectopic pregnancy, a multi-centered prospective cohort study, basically kind of proves, that was the research that I was talking about, that that's right. Like, women or birthing persons experience miscarriage, early loss, and ectopic pregnancy loss as a traumatic event. So what they did is they looked at symptoms. So people were having nightmares, flashbacks, intrusive thoughts, avoidance. So those are all symptoms of PTSD, right? And these women were, and they evaluated about 700 different women and asked them at different times post-loss what their symptoms were. And they all had them at varying amounts. But the really interesting piece was that after a miscarriage or ectopic pregnancy, 1 in 6 women kind of identified of having PTSD a year later. So even a year after their loss, they're still experiencing these intense trauma symptoms. And then one of the research lead, Dr. Tom Bjorn, I'm bad at last names, I apologize, or maybe it's Born, like the movies. Early pregnancy loss is associated with a significant level of psychological distress, and in particular, on the order of 20% will have PTSD that persists at least 9 months after the loss and probably longer. So this all really matters because as we're thinking about losses, as the loss is happening, people are also thinking, and after the loss happens, parents are thinking about when they can try again, when they can continue to build their family. I'm just gonna skip over, well, I guess not. So it's important to take all of this loss information into perspective as we start to head into the subsequent pregnancy. Again, here's just a little difference about what is grief and what is trauma. So grief is this non-pathological, normal, natural response to losing something or someone you love. And grief is about remembering the deceased as part of an adaptation, reorganization, and recovery, like learning to integrate them into your life, into their lives. So, but trauma is more like, as we're learning about trauma, it's a really fascinating and emerging field that I think more of the public is learning about. Maybe that's social media, maybe that's TikTok, maybe it's because we've all been through some really tough 2 years now, but trauma is stored in the body. So trauma is often overwhelming, stressful, and it's not integrated. Our sensory memories will experience it, and it's not necessarily cognitive in nature. We're not trying to think of the trauma, it's just happening to us, our body's remembering. So that's important to know about as you're working with your clients and patients, that some of these responses are trauma and some are grief. And it can be helpful if you send them to treatment to know the difference, because usually as a psychotherapist, I will use, and we'll get to this later, but I will use trauma-informed therapies like EMDR, ART to help treat the traumatic birth or the traumatic loss of a pregnancy or a baby. But we'll use different strategies that are more like continued bonds of attachment. How do they still continue to connect to their baby that died? And that would be more grief processing. How do we create rituals around and ceremonies around their grief? Oh, sorry, I moved ahead. So that would be some interventions where they would vary based on those symptoms. So perinatal loss and perinatal mood and anxiety disorders, or as we call them for short in my field, PMADs, losses, miscarriage, neonatal death, stillbirth, selective termination, elective abortion, they're all frequent exacerbating factors for postpartum anxiety and depression. That has been found throughout studies for the past 10 years, according to the 2 studies that are referenced here. And some form of psychological distress is often accompanies a pregnancy loss that can then lead into being a risk factor for perinatal loss or for perinatal mood and anxiety disorders. So other risk factors for PMADs and loss, younger parents, research shows, are more likely to have distress after perinatal loss and be at a higher risk for PMADs. Previous mental health history during or before a pregnancy. So this is interesting. If we go to a study we're going to talk about in a minute, they have a time frame that matters somewhat about if someone's going to experience anxiety during their subsequent pregnancy. We'll get to that in the subsequent pregnancy section. But if they had a loss within the last previous year and then subsequently got pregnant, they were more like, and they seeked mental health treatment, they were more likely to experience and be at risk, will experience anxiety and be at risk for perinatal loss and mood and anxiety disorders. People with lower income are at higher risk for these PMADs. Complicated grieving factors, which I think perinatal loss has an overlap and kind of treads into that area. And so like having a traumatic event or viewing the loss as a traumatic event, as most birthing people and parents, partners as well, sometimes do. And being a BIPOC population, And that risk factor is more about institutional racism and implicit bias within the healthcare system. But the most common psychological disorders reported because of perinatal loss is depression and anxiety. It's important to note that BIPOC perinatal loss parents experience a greater number of symptoms of PMADS. So research suggests that BIPOC moms or birthing persons, they did it on women identifying as, or people identifying as women, are more at risk for developing postpartum depression and related conditions than white women after perinatal loss. And Black and Hispanic mothers, birthing persons, were more likely, 43.9% and 46.8% respectively, to report depressive symptoms than white mothers after a perinatal loss. So keeping all that in mind, okay, we got enough time. That's how we get to the subsequent pregnancy, right? Like that's everything that happens before it. And that's why we're talking about the subsequent pregnancy, because this was a very traumatic event, a very grief-laden event. And now what they're going to do is a lot of families want to figure out how they can continue to grow their family. They make space for the baby that died. I'll talk about that as we go along, but also make space for the baby that's coming. And that's how we get to the next stage in this process of becoming pregnant again after a loss. So this is the mental health of the parent pregnant again after a loss, knowing that 50 to 80% of women and parents who experience pregnancy loss, stillbirth, and infant death go on to have a subsequent pregnancy within a year to 18 months after their loss. So this is a situation a lot of parents will go through, especially since 1 million pregnancy losses occur in the United States each year. So it's important for us to understand the unique psychological experience of these parents. So the mental health of the PAL parent, it's important to note, as I'm sure you do, which is why you're here, a previous pregnancy loss puts a PAL parent at a higher risk for perinatal, postpartum, and anxiety disorders, not just after their loss, but specifically during their subsequent pregnancy as well. So this is the study I was talking about. This is a really great study, a more recent one I was looking at, the effects of pregnancy loss on subsequent postpartum mental health. So this is a longitudinal cohort study that was done in 2020 or released in 2020 about women's mental health in the postpartum period after having a live birth after a loss. So some really interesting statistics from this new study are that women with a prior pregnancy loss history were 35% more likely to require what they call PPT, which is in their study postpartum psychiatric treatment. And about 58% of those whose first mental health treatment, so that's MHT, was after a pregnancy loss. And then over 99% of women with a history of mental health treatment 1 year prior to their first pregnancy loss required postpartum treatment after the first live births. So this is kind of talking about if they're already experiencing mental health symptoms before their pregnancy loss or even after their pregnancy loss, lots of people require continued mental health treatment after having a living baby after a loss, which I thought was really interesting. And there is a risk of inpatient treatment was higher in this population, about 83% higher for those with a history of pregnancy loss. But it's important to note the study even reported that most people seek outpatient treatment. And pregnancy loss prior to a first live birth increases the risk of postpartum PMADS, basically before and after controlling for mental health history. So that kind of goes back to that other point that if a person has a pregnancy loss as their first experience of pregnancy, which I've also found in my practice, which I'm sure you have, there seems to be an increase in anxiety or it's a higher risk factor, which correlates with that research we found before, like not having any living children kind of can exacerbate or bring on more postpartum symptoms. So it's important to note that the experience of pregnancy loss is a new layer of grief or re-grief. Sorry, I have these pop-ups. And increased symptoms of anxiety, often described by perinatal loss parents as a time of grief and joy, hope and fear. I'm sure that sounds familiar with you if you work with this population. It's this balancing act. I work I saw one lost dad yesterday, and their baby was stillborn and they're subsequently pregnant almost to the end in the time period, in like about 34 weeks when they lost their daughter, and they're coming up on their subsequent pregnancy, delivering that baby. And he's like, you really like to use both and. I'm like, well, I think pregnancy after loss is really the epitome of the both and experience, holding that grief for losing one baby and the joy and excitement for the other, holding hope for another baby by being scared to death that it's going to happen again. So Joanne O'Leary is a huge researcher of like 30 plus years in the field of researching the subsequent pregnancy. A quote of hers is continued grief for one baby while wanting to be happy for a new baby coming. So it kind of describes the experience. So common themes during pregnancy after a loss share similar common themes to perinatal loss, but then there's like a new layer of experience onto it. So what some themes that happen during what I call a PAL for short is there's a new definition of pregnancy, often that includes this idea of this loss of innocence and trust in a good outcome and in your own body. So that theme of the failed body, the failed maternal body is coming back into play. Like we said, the both and, the conflicting emotions, there's grief, there's joy, there's hope, there's fear. There's often like a secondary grief during a subsequent pregnancy that I've noticed with my clients lately, where it's like, I want to be happy, I want to feel joy for this baby, it's not fair that I don't. And then, so that's like a secondary loss, like the loss of innocence, the loss of connecting to this baby and my body and trust in the universe or in good outcomes. There's this continued feeling that kind of bleeds in from the pregnancy loss into the subsequent pregnancy of isolation, feeling alone and different in their journey. We are changed forever is what some parents are quoted. And then there's this idea of ambivalence, like they're trying not to get too attached. So we'll talk about this as we go, and that's because of a fear of another loss. So it's important to note that pregnancy after loss, a lot of my clients describe it as the definition of insanity, right? Like, so you get in a car accident where you're driving and you have a passenger, and out of nowhere someone hits you and it's not your fault and your passenger dies, right? So now when you're subsequently pregnant, we're asking you to get back into that car, and you're going to stay in that car for 9 months, and you're going to get this other passenger to the place you're going without randomly having the universe give you bad luck again. And you can never get out of that car. You can't get out of that traumatic experience. So subsequent pregnancy, you're going to expect anxiety. And it's important to know that some people in the field, like Joanne O'Leary and some of her colleagues, describe it as pregnancy after a loss. Like most people are having a normal reaction, anxiety, to the abnormal experience of being subsequently pregnant after a loss. So the expected anxiety you might see in your clientele or patients are a fear of another loss. Is it going to happen again? Like I said, that lack of trust in your own body. There's going to be increased anxiety around appointments and just different milestones in the subsequent pregnancy. So ultrasounds are often where, more often than not, where a pregnancy loss is confirmed, or where the life-limiting diagnosis is given, or where this journey is kind of started of pregnancy loss or going into this losing a baby. So ultrasounds are a huge piece of the pregnancy after loss journey that can increase the anxiety as they approach. Even if you had your loss confirmed, like I did late at 40 weeks with an ultrasound machine, I still had, and my clients do, anxiety about any ultrasound involving the pregnancy, even early dating ultrasounds and others of those. So there's increased anxiety around ultrasounds, also anniversaries. So in a subsequent pregnancy, there's 2 anniversaries and they might not correlate. So there's the anniversary of when you actually lost your baby, so the date the baby was born or you lost the pregnancy. And then there's also the gestational week where the loss occurred. That is another thing to be aware of, which I like to call your trauma window, the weeks leading up to and the period in subsequent pregnancy when the previous pregnancy was lost or a definitive diagnosis was given. I had a client recently who just got through her 2 weeks of where anniversary, so last year in October, like around the 1st or 2nd, she was giving given a definitive diagnosis that wasn't compatible with life. And then this whole 2-week period was, you know, rocky, re-grief, re-traumatization. Her body remembers the trauma until they terminated for medical reasons and got to spend time with their baby. So that whole 2-week period was overwhelming for her as an anniversary. But also then the trauma window is also like, if I am 23 weeks pregnant when I lose my baby and then I become subsequently pregnant, week 22, 23, 24 is going to be a little rocky for me. And a more increase in anxiety at that point is to be expected and is normal for that experience of being pregnant after a loss. You'll also see probably a lot of hypervigilance or overprotection, really cueing in to like, or tuning in to how their body feels. There's more anxiety around different bodily changes because there often is this theme like, well, if I would have caught this thing, I can prevent it from another loss from happening again. There's stress and worry, again, those conflicted emotions, and feeling of isolation and detachment, which we'll get, or what we call emotional cushioning, which we'll get to, I think, in the next slide. So that's the expected experience of the subsequent pregnancy for anxiety. Not much fun, but it can get worse and it can become more pathological. So expected anxiety, if you're trying to offer support, it would be like send them to a support group, find other peer-related programs, maybe more appointments with their providers, what's recommended in general, and what PAL parents ask for reassurance. But, you know, and I think everybody can benefit from individual psychotherapy during their subsequent pregnancy because it is such a difficult experience and there is this heightened anxiety. Well, at the same time, if symptoms become more pathological, like thoughts become obsessive, post-traumatic symptoms become pervasive, like flashbacks, avoidance of things, perceived fear of death, of their own death, inability to complete everyday tasks, hypochondria or health anxiety, hypervigilance has kind of weighted into that area instead. Phobias, chronic depression, chronic complicated grief, substance abuse, suicidal ideation, and previous mental health diagnosis or past trauma are really aggravated or activated by the loss. That would be when I would highly recommend individual counseling versus with expected anxiety, I would suggest it. So symptoms of PMADS in a subsequent pregnancy, in studies, birthing persons, or it wasn't really birth, it was women, but I use birthing persons to be more open about who experiences birth. But they reported high rates of symptoms of anxiety on the pregnancy anxiety scale, including increased fear and anxiety, more worries and stress, more symptoms of PTSD, more depressive symptoms, and more continued grief. So this is one study that just verified all of the previous information we reviewed as the normal subsequent pregnancy experience. And like we said, a previous loss is a risk factor for experiencing PMADS during and after their subsequent pregnancy. So there are risk factors for developing pathological symptoms in PAL. So the history of a previous mental health diagnosis is one. These are similar to the risk factors in loss, why it might be harder for someone or more intense of an emotional experience. There's the longer duration of gestational age is associated with higher probability of PTSD, according to some studies. An increased presence of PTSD was observed when there was a short period of time between the loss and the subsequent pregnancy. So you've probably heard about this in the field. There's this, or in this area, there's this idea that like there's differing suggestions on when should people try again to get pregnant, and it varies depending on when their loss was. Was it a first trimester loss? Was it stillbirth? Was it infant loss? Was there a C-section? All these different variables impact when you should try again, and each client or patient should have these conversations individually with their doctor. But then when you take out those individual variables and you're just talking about it from an emotional perspective, the one thing we really highly recommend to stay away from for reactivating the trauma is to not get pregnant on the same timeline as when you were pregnant with the previous baby. So for example, I have a client recently, they lost their baby on December 30th, 2019, and then they got pregnant and really in line the next year with their subsequent baby, where that baby was delivered. Their living baby now, born after loss, was delivered on January 5th. So it was a really traumatic pregnancy for her because the timeline of that pregnancy really lined up with all the milestones of her previous pregnancy. And that's kind of what we ask to maybe, as an emotional piece, stay away from. If an anxious grief pattern for after gestational loss is a risk factor for development of depression during late pregnancies, so this is referring to that complicated grief pattern. Younger mothers are more at risk, and also reoccurring losses are more at risk for developing these more pathological symptoms during PAL. Mother, regardless of the type of loss, reported higher levels of symptoms in the pregnancy following a previous perineal loss of depression. So what is the task of the parent who is pregnant after a loss? So some people, researchers, are starting to look at parenting as an act of adulthood parental developmental tasks of the individual. So kind of like Erik Erikson's stages of development, parenthood is kind of coming out as a developmental task as well. So that's an interesting concept, because then for parents who have experienced a pregnancy loss, even if they have living children, especially if they don't, this developmental task of becoming a parent is interrupted, and they're unable to complete the normal tasks of pregnancy and parenting when they have a pregnancy loss. So when a subsequent pregnancy happens, parents are actually walking this tightrope of grief and joy, hope and fear, of attaching and completing the developmental tasks, and fear that they won't be able to, that were interrupted in the previous pregnancy during the next pregnancy, if that makes sense. So there's more hesitation about these developmental tasks in pregnancy and becoming a parent, and there's more like identity instability. Am I a mother? Am I a father to the baby that died and the baby that's coming? And is this going to happen? So the developmental task of the PAL parent is really to, when the best intervention we use, besides treating the anxiety symptoms with coping skills, is to really make space to grieve the baby that died, to create space for the baby that is coming. And we do this by continuing those bonds of attachment. So continuing bonds of attachment, oh, I didn't put it in here, I can't remember. It was a research theory in the 1990s that came about that counteracted the idea of the stages of grief, and saying that you actually continue to have a relationship with your loved one that died. And that is actually what's encouraged when it comes to grieving parents about a baby that died. The more we can have rituals, do letter writing, have mementos, have ceremonies, and continue somehow connecting to the baby that died any way that's possible, the more we see that baby as an individual, and then the next baby, and by doing so, we create space for the next baby on the way. And we can create space to bond with both babies, and we bond better with the baby that's coming by bonding with the baby that died. So the baby that's coming is a sibling and not viewed as a replacement. And we create this space for baby on the way by creating bonds with the baby. So monitoring movements is a way to create bonds. Creating items or getting the spaces ready for the baby, or celebrating the baby by buying items. But we want to be careful when we encourage this with clients, because that can take a while. And I'll talk about emotional cushioning here in a second. So the developmental task of the PAL parent continued is saying that you want to expect and then normalize, oh, there it is, the emotional cushioning that can happen. So it takes 9 months of pregnancy to attach to a baby, sometimes longer in the post-birth period. And feelings of detachment after birth are quite common for the pregnancy after loss parent, and they should dissipate over time. But what we want to do is we want to let what we call the baby leads the way, which is Joanne O'Leary's research, and this idea that parents are going to emotionally cushion. And some people in research were curious if emotional cushioning is actually detachment from the baby. And is that going to form a poor attachment to the baby once they're here? And it was really interesting because as someone who's been through this, I get it. Like, you don't want, that's what that ambivalence piece is. You don't want to get too attached to something that isn't guaranteed after what happened last time. Like the fool me once, shame on me, fool me twice, or fool me once, shame on you, fool me twice, shame on me. But research has found this idea of emotional cushioning. So the detachment from baby is actually a protective factor at first. The symptoms of anxiety decrease as the pregnancy progresses. That's what we mean the baby leads the way, and we gain confidence in this new pregnancy and that the baby is coming and hopefully will conclude favorably or in the direction of what we want. And this fosters a bond with the future baby. And some people actually in research have found that the increased anxiety during a subsequent pregnancy and this emotional cushioning of not wanting to attach it's really weird. So listen, it's this idea that the parents are attached, and that's why they're afraid to attach, because it's like a self-protective mechanism, but it doesn't mean they're not attached. The detachment means that the wanting to detach means that they're already attached, if that makes sense. And when I explain this to my loss clients who are pregnant again, they really resonate with that. So it does make sense to them. And people will attach more as like the kicks come and the belly grows and the ultrasounds increase. And but it's usually about asking them to bond with baby. We can bond with movements as we get later on. We can bond with buying things. We also want to be careful because of this emotional cushioning. Often bonding is like dipping their toes into the water and then going back up on shore. Not a lot of them are really ready to jump in head first until they have what is often said in our community, that breathing baby in our arms. So monitoring baby movements is one way to bond with baby. I hear next week you're gonna have a whole presentation on this, but this is the new suggestions about how to monitor baby movements. So it's more about daily patterns and frequencies and strength, and also sleeping on your side is important after 28 weeks. But monitoring these movements, some people call it like parenting before birth. Setting aside time to check in on baby can help bond and increase that attachment and decrease the detachment. But again, some clients don't like monitoring movements because it reminds them of their previous loss. So there could be harder conversations to be had there too. So I'm noticing the time, so I'm going to try to get through as much as I can here, and I'll end in a few minutes for questions. So it's important to note that there's also a partner's PAL experience, and a lot of this research, unfortunately, has been done on heterosexual couples. And I do believe another area in the field, besides expanding research into the BIPOC community, is also expanding research into same-sex couples and different gendered identifying parents, and more research needs to come as we become more diverse in our understanding of humans. So, but the partner's PAL experience is this idea that they need recognition too. One of the themes for PAL dads specifically is that the parents or friends and family will ask about the birthing person, but won't ask about how the dad or the father or the partner is doing, and their feelings are often downplayed. They also have a constant worry and anxiety, but they feel like they have a lack of control because there's this lack of reassurance from baby. The baby leads the way with the mom. The birthing person can check in on the baby on the baby's movements, but the partner doesn't have that reassurance, so they often feel helpless. And the theme that comes about, even in early pregnancy loss, all the way through infant death, after loss, and then during a subsequent pregnancy, is the partner prioritizes the needs of the birthing person, and they delay their own needs, which can come up as regrief later. And there's like the staying strong for partner mentality that often needs to be challenged because they also need support around this anxiety-provoking experience. So what are the evidence-based support interventions for the subsequent pregnancy, following loss? I got a minute here. So psychoeducation, really normalizing the experience. What is the grief process? What is normal pregnancy after loss experience? What to expect? Risk factors, let them know they are at risk for perinatal loss and perinatal mood and anxiety disorders and what to watch out for. Teaching them coping skills, so like distress tolerance, emotional regulation, mindfulness. How do I cope just getting through this moment? And how can you connect to the baby and bond when you are ready, or taking little leaps of faith in doing so. It's important to know you can refer to support groups. They're often recommended and highly effective. In-person support groups may not be helpful for young Black women, though a new recent study showed, and I've seen this in my practice as well. Younger moms and moms who identify as BIPOC sometimes don't relate to the culture of those support groups that are that are currently out there for pregnancy after loss and loss. Oftentimes couples are married and a younger woman will say she's not married, so she doesn't understand that, or there's cultural considerations to take into place of the differences and concerns between BIPOC populations and then mostly white populations. One thing we've noticed though too is that online communities and peer-to-peer support forums are often successful. And it was said in this study, as well as 2020 study by Fenschmacher and Hupsey, I can't say their names, that young Black women might benefit from reading other bloggers or Instagrammers who are also BIPOC identifying themselves and have been through loss. That would be helpful. And it's helpful for everybody, regardless of their racial identity, hearing successful stories of others who have been through it. However, the online loss community, as of like 2 years ago, when I did my presentation on grieving online, was mostly geared around upper class white women or mothers who identified as women for some reason. So it'd be interesting to see how that information might have changed in the last 2 years, because more online spaces are developing for BIPOC communities, specifically around pregnancy loss. This is the study of psychoeducation. This study in Iran proved that psychoeducation and validation of the PAL experience was helpful in reducing symptoms of anxiety in their population when they implemented this intervention. Therapy is also great. I kind of mentioned that already. When to recommend therapy, I suggest it for the subsequent pregnancy typical experience of anxiety. I highly recommend it if there's a trauma, more of a trauma response, and there often is both. Mindfulness types of therapy, so CBT, DBT, are super helpful for grief and for subsequent pregnancy. And then EMDR or different kinds of trauma treatments are really good for that birth trauma of the experience of the loss. It's important to know, though, that CBT reframing skills are not as effective during a pregnancy after loss. So you're not going to think their way out of this experience of anxiety when they're pregnant for 9 months, because it's really like this body response, this trauma response. So it's more about how do you calm the nervous system down, more of that polyvagal theory, completing the stress cycle by Emily Nagoski, or really just attending to the body to calm it down. So there's a lot of barriers for BIPOC to therapy specifically, though. Because of the institutional racism and implicit biases within the structure of the larger healthcare system and psychotherapy, it isn't often the first line of support for BIPOC communities. Some research has shown, especially in that study I was looking at about the young Black mothers, they find a lot of support from their grandmothers and their church and other maternal figures in that regard. We also knew in this study, I found that Edinburgh Postnatal Depression Scale and survey may be less likely to deliver accurate results for BIPOC communities because of possible stigma around mental health within the BIPOC communities, but also because of this, that didn't have to do with loss, but this study that saw that Black women and men in breast cancer and prostate studies use different terms for scaling emotions. So more likely to admit to feeling low, blue, or down than depressed. So the language we use is also a barrier to accessing these services. Complementary healing practices are great as an intervention as well. They really help calm that nervous system and that body down, getting them out of their head. And then real quick, I put too much in here, but it's all great. So the emotional supportive health care during subsequent pregnancy, there is since 2016, the Rainbow Clinic in the UK kind of got together this initiative with Dr. Hiesel to kind of figure out what would be the standards of care, because there wasn't before 2016, of how do I implement emotional and physical standards of care across the world for the mom or the parents who are subsequently pregnant after loss. So there's special considerations in care. So here's Dr. Hiesel's study, and then actually just wrapped up in 2020 or 2021, where they're starting to and analyze the data that's coming out from these research findings. And what they found is parents during subsequent pregnancy really require additional psychological support to navigate the mixed emotions, particularly the anxiety, antenatal care in subsequent pregnancy after stillbirth. And this is after stillbirth specifically though, should ideally be delivered in a multidisciplinary team to provide continuity of physical and psychological care, and greater attention is required to providing thoughtful, empathetic, and collaborative care in all pregnancies following stillbirth. Specifically, educational training like this to healthcare professionals about what is needed. So we did a study in 2019 with our own community of pregnancy after loss support. And what we found, it aligns with Dr. Hesel's study after 344 members of our community answered, and that they all had these increase in symptoms, right? Of fear, stress, trauma, depression, still excitement, continued grief. And they all had varying types of losses. And just like the online studies show, online communities are mostly white. So that's something we're working on in our specific community as well, but those are the ones who respond. So that aligns with the data for who's using the online groups for grieving. Women of color have the same rates of symptoms of depression and PT symptoms after perinatal loss, but they also have dramatically higher rates of perinatal loss than white women. However, they're not accessing these services, probably because we're not getting at them because of surveying the communities like we are doing or like we did. So this is a fault in the study of how we surveyed our own community. And we need to look at ways at getting more of the data from BIPOC communities about how to support them during a subsequent pregnancy. But what we found out, or I should say, and what we found out from the surveys of our own communities is that what a PAL parent wants from their provider is ranked in order from top to bottom here, and it aligns with what Dr. Hesel's study is suggesting for special considerations in care across the PAL experience. So it was really interesting when we did this though, because we thought that using the child's name in conversations with the patient was most important. And I would say it's most important for those who've had a stillbirth or who have named their baby. However, it is not the thing that ranked most important during their considerations in care. So our clientele in the community was saying they want healthcare providers to understand the unique emotional experience of pregnancy after loss. Remember that a lost mom needs reinsurance, or parents, they need those extra visits, the heart tone checks. When you go to an ultrasound, they want to see that there's a heartbeat before you do all the testing. They want help to reduce their anxiety. They want you to provide concrete medical information. They want you to educate yourself on emerging resources, so like what's out there and what communities are out there to support. They want to know their risk factors for mental health disorders in early parenting. They want to know what to anticipate and during early parenting of this new baby, and also like this detachment and anxiety is normal. Also, and then realizing that one baby does not replace the other. They're not just magically happy again that they're pregnant after they lost their other baby. Understand the relationship between the lost mom and her body is complex, and acknowledge their grief and fears. And you can see the rest. But this is the order of what they were saying, which really aligns with what Dr. Hesel's study showed. So here's some cards that PALS put together to help providers. So pause, acknowledge, listen, and support is really what these parents want during their subsequent pregnancy visits with healthcare providers. And we really want to take a holistic approach. So full medical, holistic, biosocial team approach is what's best for care during the subsequent pregnancy. So referral to educational support groups, in person or online, special org therapy if it seems appropriate or necessary, special considerations in care for medical providers, ultrasound techs, nurses, doulas, therapists. Again, when there's trauma, individual counseling or couples counseling, and then increase the public discourse in everyday environments. And it said mothers who shared their PTSD symptoms from perinatal loss with outside networks were associated with fewer PTSD symptoms later on. So these are suggested emotional care for PAL during subsequent pregnancy, increased visits with mental health provider to weekly, teach, encourage, and support advocating techniques of birthing in person with the care providers, especially BIPOC patients. Notice and taking into consideration that structural racism within the healthcare system and how prenatal care is administered differently to white versus Black birthing persons are barriers to interventions for the BIPOC community. And then continuing on with suggested emotional care for PAL parents, You want to increase that open door policy with perinatal or prenatal visits, increase monitoring appointments, treating this pregnancy as high risk, even though it is only due to the previous loss. It is suggested in some research and from clients that they get to see the same medical provider for all appointments. They don't necessarily love the clinic care model where they see multiple different providers within the practice. They want medical professionals trained in pregnancy loss and the emotional health and mental health experience of the birthing person during their PAL. They need reassurance. They need an understanding approach. They need acknowledgement and encouragement. And what I'm seeing more so in my area, and I don't know if it's happening in yours, when I had my loss, I did not have a consult with the maternal fetal medicine before my subsequent pregnancy or to see how my care would be. But what I'm seeing emerge in the last 9 years with my clients now is most clients who experience in our area a pregnancy loss, specifically preterm or stillbirth, will get a consult with a local maternal fetal medicine doctor, which I think has really helped some of my clients' experience of relieving the guilt, because there's often an expert that says, no, that panic attack you had a day before your baby was stillborn did not cause your baby's stillbirth. So the professionals can be really good at validating some of those magical thinking or mistaken beliefs that I think a lot of pregnancy after loss parents carry. And then, of course, specialized childbirth education classes and postpartum groups are really that are specific to the PAL experience are helpful. This is why special considerations and care are important. More targeted interventions will decrease levels of PMADs. It will help increase bonding and attachment, and more targeted and early interventions need to occur for the BIPOC community because they experience more pregnancy loss and are often underserved. And we need more research within these communities as well. So resources, ones that I really love, so pregnancy after loss support, which I helped found. We offer peer-to-peer support. We're kind of like the baby center for pregnancy after loss. And we recently came up with an app that's free, that you can download on Apple or Google Play, and it walks you through what to expect weekly from the unique emotional experience of pregnancy after loss. It has 20 coping skills, meditations, forums to meet with other PAL parents, and it also helps you bond with baby by, knowing the size of your baby, journaling to baby as a coping skill, other things like that. We have articles by other PAL parents that kind of talk about the same emotional experience. Return to Zero Hope is a great resource. They're located out of the West Coast, LA, but they're nationwide, and they help spread information specifically about perinatal loss to hospitals and do educational credits for providers, like short, very affordable 1-hour CEU courses online. They used to do retreats before the pandemic, and now they offer 6-week support groups for different areas of different subsets of the population, of the perinatal loss population. Star Legacy Foundation, which is in Minnesota, helps prevent stillbirth, and they have a national summit that brings all of these researchers on stillbirth together to help further the prevention of stillbirths, so that's great. And then there's Sisters in Loss, which is one of the first emerging BIPOC, specifically Black women community who experience pregnancy loss, run by Eric McFay, and she's out of the East Coast. And I actually believe Sisters in Loss was just recognized at the Maternal Mental Health Conference that Vice President Kamala Harris held at the Capitol this past year. So that's pretty awesome and amazing. And they're recognized for their work and trying to, because they also have a doula program for BIPOC, so helping to prevent and maternal mortality and infant mortality through Black women trained as doulas. And then Postpartum Support International is a great organization nationwide that can help you find your client or patient find a targeted therapist who specializes in PMADs and pregnancy loss and the pregnancy after. So I went over, I apologize, I can stick around for questions and I have no problem, but thank you for your time. Here's how you can contact me.
Thank you, Lindsay, so much for that fabulous presentation. In the interest of time, please, I ask that if you have any questions for Lindsay, that you contact her directly.
Okay.
So Just very quickly, I do want to talk about two programs that the Partnership for Maternal and Child Health provides. One is we do have an emotional health phone support program. And part of that program is we do work with women who have suffered from a perinatal loss, regardless of their gestational age, and we work to get them connected to mental health resources in the community that they live in. And another program we offer is a perinatal loss support group that meets once a month, and it's facilitated by Andrea, who's our femur coordinator, as well as Vuan Foster, who is from Life After Two Losses. So if those are programs that you would be interested in learning more about, my contact information as well as Andrea's is in the chat box. Please feel free to reach out to us, and we would be more than happy to give you that information. That's all we have time for today. Many thanks again to our speaker, Lindsay, as well as Karim Amadeo, who is handling the technical back end of the program, and to all of you who have joined us today. A reminder that you will receive a link to a post-program evaluation. Your feedback is important, so please take the time to complete it. Certificates of completion will be sent via the email provided on the evaluation, so please make sure that that is correct and should be received in about 1 week. A calendar of the partnership's upcoming virtual programs can be found at www.pmch.org under the Professional Education tab. We also offer on-demand recordings of many of our programs, all of which are listed on our website. Thank you, and we hope that you can join us again for our upcoming educational events. Have a great day.